Good afternoon. Welcome you to this session on the anatomy of the brain. As clinicians, educators, and future specialists, we often focus on the physical injuries, the surgical fields, and the external signs. But today, we turn inward to the command center of the human body. The brain is not just a structure, it's a symphony of function, coordination, and resilience. In this lecture, we'll explore the brain's architecture from its gross anatomy to its intricate neural pathways. So let's begin our journey into the brain, not just as a biological organ, but as the seat of consciousness, coordination, and care. Let's begin with the foundation of all neurological function, the human nervous system, which is elegantly divided into two major components, the central nervous system and the peripheral nervous system, CNS and PNS. CNS. The CNS consists of the brain and spinal cord, the command center for processing, integration, and response. The brain, with its cerebral hemispheres, cerebellum, and brainstem, governs cognition, coordination, and autonomic control. The spinal cord, housed within the vertebral column, serves as a conduit for motor and sensory signals between the brain and body. Clinically, CNS lesions can present with upper motor neuron signs, altered consciousness, or central sensory deficits. Understanding its anatomy is crucial for localizing strokes, tumors, and spinal cord injuries. PNS. The PNS includes all neural structures outside the CNS. It connects the CNS to the limbs and organs, enabling voluntary movement, reflex arcs, and sensory perception. Here we see key components like brachial plexus, lumbar plexus, sacral plexus, which give rise to nerves such as radial, median, sciatic, and femoral, each with distinct motor and sensory territories. Clinically, PNS disorders often present with lower motor neuron signs, peripheral neuropathies, or nerve entrapment syndromes. For example, injury to common peroneal nerve can cause foot drop, while median nerve compression leads to carpal tunnel syndrome. Let's begin with the most powerful organ in the human body, the brain. It's not just one of the largest organs, it's the central coordinator of nearly every function we perform, consciously or unconsciously. The brain is the seat of thought, judgment, and emotion, the very elements that define our humanity. Whether it's solving a clinical problem, making a moral decision, or feeling compassion for a patient, it all begins here. Each region of the brain has a specialized role. The frontal lobe governs executive functions and personality. The parietal lobe processes sensory input and spatial awareness. The temporal lobe handles memory and auditory signals, while the occipital lobe is dedicated to vision. Beneath these, the cerebellum fine-tunes movement and the brainstem sustains life through autonomic control. Clinically, understanding this segmentation is vital. A stroke in the frontal lobe may alter behavior. A tumor in the cerebellum may cause ataxia. Trauma to brainstem can be fatal, likewise. As we move through this lecture, we'll explore how each part of the brain contributes to motor control, sensory integration, language, and autonomic regulation. We'll also examine how damage to a specific area presents in real-world clinical scenarios. In essence, the brain is not just an organ, it's a network of networks, a biological supercomputer, and the core of our clinical reasoning. Now that we have introduced the brain as the central organ of thought, emotion, and judgment, let's take a closer look at its physical structure and cellular composition. The brain is housed within the skull, weighing approximately 1300 to 1400 grams in average adult. Despite its size, it consumes nearly 20% of the body's energy, underscoring its metabolic importance. At microscopic level, the brain contains around 1000 billion neurons, each one a specialized cell capable of transmitting electrical impulses. Surrounding these neurons are glial cells, or neuroglia, which outnumber neurons by roughly 10 to 1. Unlike glial cells, neurons do not divide. Once formed, they cannot regenerate through mitosis. This means that neuronal loss, whether due to aging, trauma, or disease, is often permanent. In contrast, glial cells can multiply throughout life, playing key roles in support, insulation, and immune defense within the nerve system. Protecting this delicate network is a triple-layered membrane. This is a triple-layered membrane system known as meninges. The dura mater is the tough outer layer. The arachnoid mater is the middle web-like layer. The pia mater is the delicate inner layer that closely adhere to the brain's surface. These layers not only cushion the brain but also help regulate cerebrospinal fluid, vascular supply, and infection control. Ventricles of the brain and CSF dynamics. Now that we have explored the brain's structural and cellular foundation, let's turn our attention to its internal cavities, the ventricles, which plays a vital role in cerebrospinal fluid circulation and protection. There are four ventricles within the brain, each strategically positioned to support and cushion neural tissues. The two lateral ventricles, one in each cerebral hemisphere, are the largest and most anterior. They connect to the third ventricle via the interventricular foramina or foramina of Monro. The third ventricle lies in the middle, nestled between the thalamus and hypothalamus. The fourth ventricle sits posteriorly between the brainstem and cerebellum and continues downward as the central canal of the spinal cord. These ventricles are filled with cerebrospinal fluid produced by the choroid plexus. So the CSF serves multiple functions. It cushions the brain, protecting it from trauma. It maintains intracranial pressure. It removes metabolic waste. It contributes nutrients and hormones. From the lateral ventricles, CSF flows through the third and fourth ventricles, then exits into the subarachnoid space via the median and lateral apparatus. It's eventually absorbed into the venous system through arachnoid granulations. Ventricular connections and clinical insight. Now that we have identified the four ventricles, let's trace the pathways of cerebral spinal fluid through this system using the labeled diagram as our guide. CSF is produced primarily in the choroid plexus of lateral ventricles. From there, it flows through the interventricular foramen or foramen Monro into the third ventricle, which lies between the thalamus and hypothalamus. Next, CSF travels down the cerebral aqueduct or aqueduct of Sylvius, a narrow channel that connects the third ventricle and fourth ventricles. This is a common site of obstruction, especially in non-communicating hydrocephalus. The fourth ventricle, located between the brainstem and cerebellum, serves as a gateway. CSF exists through the median aperture foramen Magendie and lateral aperture foramina of Luschka into the subarachnoid space, so circulating around the brain and spinal cord. Finally, CSF is absorbed into the venous system via arachnoid granulations in the superior sagittal sinuses, and disruption of this flow, whether due to obstruction, overproduction, or impaired absorption, can lead to raised intracranial pressure. Now we will come to the functional overview of brain. So, what are the brain divisions? Cerebrum, cerebellum, brainstem, and diencephalon. So, cerebrum divided into right cerebral hemisphere and left cerebral hemisphere. So, high, so what are the functions of cerebrum? They do the higher cognitive functions, reasoning, memory, emotion, and language. Also motor control through the precentral gyrus, sensory perception postcentral gyrus. So what are the clinical relevance of cerebrum? Stroke in middle cerebral artery can develop congenital hemiplegia, aphasia if dominant hemisphere is affected. So frontal lobe injury may affect a personality. So cerebellum, next is the cerebellum. Its function is coordination of voluntary movement, balance and posture. So if any injury to this area, there will be ataxia, intention tremors. So likewise, so brainstem contains the substantia nigra. It does the dopamine production, lesions, may cause Parkinsonism features. So in the midbrain, there are three parts: medulla, pons, and the midbrain. In the brainstem, yeah, the brainstem, medulla, pons, and midbrain. So now, finally, diencephalon. It houses thalamus. So this thalamus is the relay station for sensory input except olfaction. So lesion is thalamic pain syndrome may produced hypothalamus. Its main role its plays main role is homeostasis. So and it controls the pituitary gland, circadian rhythm, temperature, hunger, thirst, waste. Uh, then there will be epithalamus and pineal gland. It's related to the melatonin secretion, which governs the circadian rhythm regulation. Let's now explore the sagittal anatomy of the human brain, not just as a static diagram, but as a dynamic map of function, pathology, and clinical relevance. Let's begin with the cerebral cortex, the outermost layer. This is the seat of higher cognition, language, memory, voluntary movements. Beneath it lies the corpus callosum, a thick band of white matter that bridges the two hemispheres. In trauma or demyelinating diseases, disruption here leads to split brain phenomena or interhemispheric disconnection. Cerebrum, the structure, development, and clinical insight. Now that we have established the cerebrum as the largest and most functionally dominant part of the brain, let's explore its developmental dynamics and clinical relevance. During embryogenesis, the cerebral cortex, our gray matter, undergoes rapid expansion. This outer layer, just 2 to 4 millimeter thick, contains billions of neurons responsible for processing sensory input, initiating motor commands, and integrating higher cognitive functions. As the cortex grows faster than the underlying whiter matter, it begins to fold upon itself. These folds form the guidi, or ridges, and sulci, or grooves, dramatically increasing surface area without expanding cranial volume. This folding isn't random. It's regionally specialized. For example, the precentral gyrus or the frontal lobe governs the voluntary motor control. The postcentral gyrus or parietal lobe processes somatosensory input. The superior temporal gyrus is key for auditory perception and language comprehension. The occipital lobe, the posterior, is the visual processing powerhouse. Let's not forget the functional lateralization. The left hemisphere typically dominates language, logic, and analytic tasks. The right hemisphere excels in spatial awareness, creativity, and emotional nuance. Clinically, this matters. A stroke in the left middle cerebral artery may cause aphasia, while a right side lesion might impair spatial orientation or facial recognition. Now, consider the cortical layers. 6 histological strata, each with distinct neuron types and connectivity. Layer 4, for instance, is rich in sensory input from thalamus, while layer 5 sends motor output to the spinal cord. This microarchitecture underpins everything from reflex arcs to abstract reasoning. In neurodegenerative diseases like Alzheimer's, cortical thinning and neuronal losses begin in the entorhinal cortex and hippocampus, then spread to association areas. What are the early signs? There may be memory lapses, disorientation, and executive dysfunctions. In trauma, the frontal lobes are most vulnerable due to their proximity to the bony skull. Patients may present with disinhibition, poor judgment, or personality changes, often misattributed to psychiatric causes. So, when we teach or examine the cerebrum, we are not just labeling parts, we are decoding the architecture of thoughts, emotion, and action. Every sulcus tells a story. Even every gyrus holds a function, and every lesion reveals the elegance of its design. Yeah, cortical topography and hemispheric architecture. Now let's see. Now turn our attention to the topography of the cerebral cortex, a landscape of folds, grooves, and divisions that reflects both evolutionary complexity and functional precision. The raised ridges on the cortex are called gyri or convolutions. These aren't just anatomical curiosities. They house the functional zones of the brain. For example, the precentral gyrus is the primary motor cortex, postcentral gyrus is the primary sensory cortex, superior temporal gyrus handles auditory processing and language compression as we mentioned earlier. So between these gyrus lies grooves. The shallower grooves are called sulci, while the deeper ones are known as fissures. The most prominent is the longitudinal fissure, which divides the brain into right and left cerebral hemispheres. Each hemisphere is further subdivided into four lobes: frontal lobe, executive function, and motor control, speech production. So parietal lobe, responsible for sensory integration, spatial awareness. The temporal lobe, responsible for memory, emotion, and auditory processing, and occipital lobe, responsible for visual perception. We discussed this matter earlier also. Now, although these hemispheres appear symmetrical, they are functionally lateralized. The left hemisphere typically governs language and analytical tasks, while the right hemisphere excels in spatial and emotional processing. This is why a left MCA stroke may cause aphasia, while the right side lesion might impair facial recognition or neglect. Connecting these hemispheres is the corpus callosum, a dense bridge of nerve fibers that allows interhemispheric connection. In conditions like multiple sclerosis, demyelination here can cause split brain symptoms or interhemispheric disconnection. Clinically, understanding this architecture is vital. A lesion in the frontal lobe may present as personality change or executive dysfunction. Damage to parietal lobe can cause sensory neglect or apraxia. Temporal lobe pathology may manifest as memory loss or complex partial seizures. And occipital lobe leads to visual field defects. So even you examine a patient or interpret in a imaging, think in terms of guideline and sulci, lobes and hemispheres, function and defunctions. The cortex isn't just folded, it's functionally sculpted. Lobe anatomy, surface landmarks, and clinical mapping. Now that we have visualized the brain from above, let's decode the lobe layout and its functional implications. The central sulcus, a key landmark, divides the frontal lobe anteriorly from the parietal lobe posteriorly. This groove separates two critical gyri. Now you got the point. The central sulcus, a key landmark, divides the frontal lobe anteriorly from the parietal lobe posteriorly. This groove separates two critical gyri, precentral gyri or frontal lobe. This is the primary motor cortex as we know now, and postcentral gyrus, its parietal lobe, primary somatosensory cortex. So damage anterior to the central sulcus affects motor output. Okay. So damage anterior to the central sulcus affects motor output. Think hemispheresis or expressive aphasia. So posterior damage impairs sensory input, leading to numbness, neglect, or asterogenosis. So moving posteriorly, the occipital lobe, colored in green here in this diagram, is the visual processing center. Lesions here cause visual field defects, often representing the vertical midline due to often respecting the vertical midline due to optic tract organization. The frontal lobe, shown in pink, governs executive function, speech production, so Broca's area in the dominant hemisphere, and voluntarily movement. Frontal lobe trauma or tumors may present subtly with personality changes, poor judgment, or disinhibition. The parietal lobe in blue integrates sensory input and spatial awareness. Right parietal lesions often cause contralateral neglect, while left-sided damage may impair calculation and writing. So we call it Gerstmann syndrome. Let's not forget the gyri and sulci. These faults aren't random. They reflect cortical specialization. For instance, superior frontal gyrus work in memory and attention. Supramarginal and angular gyri, language comprehension and reading. Calcarine sulcus, or which is in occipital lobe, primary visual cortex. Clinically mapping symptoms to lobes is essential. A patient with sudden speech difficulty and right-sided weakness likely has a left frontal lobe stroke. A person with visual hallucination or field cuts may have occipital lobe involvement. And remember, the longitudinal fissure divides the hemispheres, but the corpus callosum bridges them. In split brain syndrome, patient may struggle to name objects seen in the left visual field, despite being able to draw names, highlighting interhemispheric discontent. So, when you examine a patient or interpret imaging, think in terms of lobes, landmarks, lateralization. The surface anatomy isn't just decorative, it's diagnostic. Hemispheric control and clinical localization. Now that we have visualized the hemispheric layout and lobe anatomy, let's reinforce a foundational principle. Each, each cerebral hemisphere controls motor function on the opposite side of the body, a concept known as contralateral control. Contralateral control. This crossover occurs at the level of the medullary pyramids, where descending motor fibers dissect. So, the left cerebral hemisphere governs the right side of the body. The right cerebral hemisphere governs the left side of the body. Clinically, this is crucial. A stroke in the left motor cortex, specifically the precentral gyrus, will result in right-sided hemiparesis. If the lesion extends into Broca's area, the patient may also present with expressive aphasia. Conversely, a lesion in the right parietal lobe may cause left-sided neglect, where the patient ignores stimuli on the left side of their body or environment, despite intact motor and sensory pathways. Let's apply these to real-world scenarios. A soldier with sudden right arm weakness and slurred speech likely has a left hemisphere infarct. A trauma patient with left-sided facial droop and limb weakness may have a right hemisphere contusion. And remember, motor coordination isn't just cortical, it's modulated by cerebellum, also exhibits contralateral influence via double decussations. So a right cerebellar lesion may still affect the right side, depending on the tract involved. The principle of contralateral control is the cornerstone of neurological localization. It transforms imaging into insight and symptoms into strategy. Functional mapping of cerebral lobes. Now that we have visualized the lobes of the cerebrum, frontal in this diagram, frontal in blue, parietal in yellow, occipital is in green, and temporal is given in pink. So let's decode their functional roles and clinical relevance. Frontal lobe marked in blue, yeah, their main functions are executive control, voluntary movement, speech production in Broca's area in dominant hemisphere. So what type of lesions can be produced if this zone is affected? Contralateral motor weakness, personality changes, de-inhibition, and expressive aphasia if Broca's zone is involved. We are repeating these things because you have to get uh, thorough knowledge on these areas. So then we'll go to the parietal lobe, which colored in yellow. So functions are sensory integration, spatial awareness, proprioception. Lesions in this area may cause contralateral sensory loss, hemineglect, especially right parietal lobe, apraxia, and dyscalculia. So especially in the left parietal lobe. So you can see here most posteriorly occipital lobe colored in green color. It's mainly visual cortex, as you know already. So lesions may be immunopia, visual hallucinations, and cortical blindness. So then you see the temporal lobe, which colored in pink. It's auditory perception, memory, motion, and language comprehension, Wernicke's area. So from the temporal lobe, we'll shift into the cerebellum, which is colored in orange color. Main functions are coordination, balance, fine motor control. So lesions, what we get is ataxia, dysmetria, intention tremors, nystagmus. So these are the outline of the lobes of cerebrum. Frontal lobe is the executive, command, and motor control. Let's now zoom in on the frontal lobe, the brain's command center, highlighted here in this our diagram and located beneath the forehead, anterior to the central sulcus. This lobe governs constellation of high-order functions. Motor control via primary motor cortex, precentral gyrus, speech production through Broca's area, as we know already. This is in the Broca's area in the dominant hemisphere. Executive functions such as reasoning, planning, judgment, and problem solving. So now you thorough that these important executive commands and control done by the frontal lobe. So they do the emotional regulation and personality traits depend on the frontal lobe. So you can think it as the CEO of the brain, setting goals, initiating actions, and modulating behavior. So we'll see what are the functional zones within the frontal lobe. Prefrontal cortex, it's for decision making, impulse control, and for social behavior. Next, we'll see premotor area, which is important, responsible for motor planning and coordination. So primary motor cortex, they are responsible for voluntary movements, organized symptotopically. So it's organized symptotopically. So then we'll see the Broca's area. It is responsible for speech articulation. So what are the clinical correlations of these lobes? We'll see what are the clinical settings, what we can see. Frontal lobe stroke, what will just think what would happen if a frontal lobe stroke? Its affect contralateral hemiparesis. Now you know it's contralateral hemiparesis, especially face and arm. So trauma or tumor in frontal lobe may change patient's personality. There may be disinhibition or poor judgment. So you know what is Broca's aphasia? It's non-fluent, effortful speech with preserved comprehension. So in trauma settings, frontal lobe injuries are common due to its anterior position and proximity to the bony skull. So patients may present with subtle behavioral changes before overt motor deficits. So you have to keep it in your mind. So sometimes they'll just produce behavioral changes initially. So always correlate with imaging and collateral history. Always keep this in your mind. Parietal lobe, it's for sensory integration and spatial awareness. Let's now shift our focus to the parietal lobe, the more superior portion of the cerebrum, positioned at the crown of the head, just posterior to central sulcus. This lobe is the brain's sensory hub. It's responsible for receiving and interpreting tactile input such as touch, pressure, temperature, and pain, then integrating spatial orientation, proprioception, and body awareness, processing language comprehension in the dominant hemisphere, especially the angular and supramarginal gyri. So the primary somatosensory cortex located in the postcentral gyrus. So primary somatosensory cortex located in the postcentral gyrus. So is somatotopically organized, forming sensory homunculus. This allows precise mapping of sensory input from each body region. Functional zones within the parietal lobe: anterior parietal cortex for raw sensory input, posterior parietal cortex for spatial processing, attention and integration, dominant hemisphere for reading, writing, calculation, non-dominant hemisphere, visuospatial awareness and attention. So you see, if patient is having right parietal lesion, he will get leg-sided neglect, nausea and receive apraxia. If patient is having left parietal lesion, he he will produce agraphia, acalculia, finger agnosia, left-right disorientation. So, patient is in sensory cortex damage. He will lose loss of tactical discrimination, astereognosis, impaired proprioception. In trauma or stroke, parietal lobe deficits may be subtle. Patient may ignore one side of their body, misjudge spatial relationships, or struggle with basic arithmetics. Always correlate with the bedside sensory testing and functional tasks. Occipital lobe, visual cortex, and clinical mapping. Now we are arriving at the occipital lobe, the most posterior portion of cerebrum, nestled at the back of the head and highlighted in red color in our diagram. This lobe is the brain's visual processing center, receiving input from the eyes via the optic nerves, optic chiasma, and optic tracts, which ultimately synapse in the lateral geniculate nucleus of the thalamus before projecting to primary visual cortex, also called the striatal cortex or V1. Now we'll see what are the functional zones within the occipital lobe. Primary visual cortex or V1 process raw visual input, light, space, color, motion. So next is visual association area. They are V2 to V5. So these area interpret and integrate visual data, object recognition, spatial orientation and facial perceptions. So now we see how we can correlate these into clinical scenarios. So unilateral occipital lobe lesion produce contralateral heminomus hemianopia, bilateral occipital damage. Now you have damage to both sides. So it will cause cortical blindness with preserved pupillary reflex. So it's not affecting pupillary reflex, but there is bilateral cortical blindness. Visual hallucination or visual agnosia is association area dysfunctions. So importantly, occipital lobe strokes often spare macular vision due to dual blood supply from the posterior cerebral artery. So it's a gift from the God, and middle cerebral artery branches, a phenomenon known as macular sparing. In trauma, posterior fossa tumors, occipital lobe involvement may present subtly. Patients may bump into objects, misread text, or describe missing parts of their visual fields. Always test with the confrontation visual field exams and correlate with imaging. Temporal lobe, the auditory cortex and memory gateways. Now we turn to the temporal lobe, the lateral portion of the cerebrum, positioned above the ears and here highlighted and with these arrow shows in our diagram. This lobe is the brain's auditory and memory center responsible for hearing via the primary auditory cortex in the superior temporal gyrus, smell through olfactory pathways that project the uncus and amygdala, language comprehension in Wernicke's area, especially in the dominant hemisphere, memory consolidation via the hippocampus, emotional processing through the amygdala. Now we see what are the functional zones within the temporal lobe. Superior temporal gyrus responsible for auditory perception, middle and inferior gyri responsible for visual and semantic processing. So medial temporal structures, hippocampus, amygdala for memory and emotions. So as we already know, Wernicke's area, it's for the fluent language comprehension. So in clinical scenario, what is Wernicke's aphasia? So you will have fluent but non-sensual speech, impaired comprehension. So likewise, temporal lobe aphasia, deja vu, olfactory hallucination, or automatisms like. So if you get hippocampal sclerosis, develop memory loss, complex partial seizures. Damage to auditory cortex may cause cortical deafness or impaired sound localization. In trauma or stroke, temporal lobe deficit may present subtly. Patients may speak fluently but make no sense, missing print sound, or experience vivid sensory hallucinations. Always correlate with EEG, imaging and bedside language testing. Cerebrum, the triad of the function. Now that we have explored the lobes individually, let's consolidate our understanding of the cerebrum's core functions, which fall into three major domains: motor function, sensory function, cognitive function. These are the triad of functions of cerebrum. Motor function governs voluntary movements governed by the primary motor cortex in the frontal lobe or precentral gyrus, organized somnotopically as the motor homunculus, control precise intentional movements, face, limbs, trunk. So what are the clinical points from here? Lesions cause contralateral weakness or paralysis. Frontal lobe strokes often spares the leg due to vascular distribution. Sensory function. So what are the sensory function here? Perception and interpretation, managed by the primary somatosensory cortex in the parietal lobe, postcentral gyrus. Process tactical inputs, touch, pressure, temperature, pain, includes auditory cortex, temporal lobe, visual cortex, occipital lobe, and olfactory centers. So then cognitive function. So intelligence, language, memory distributed across frontal, temporal, and parietal lobe. speech by the broadcast area, and speech production is by the broadcast area, and comprehension by the Wernicke's area, memory from the hippocampus and medial temporal structures, learning and reasoning from the prefrontal cortex and associated area. So, cerebellum, precision, balance, and motor harmony. Now we descend to the cerebellum, the second largest portion of the brain, nestled between the posterior cerebrum and separated by the transverse fissure. This structure is the brain's coordinator-in-chief, responsible for fine-tuning of voluntary movements, maintaining balance and equilibrium, regulating muscle tone and posture, timing and rhyme of motor activity. Unlike the cerebrum, which initiates movement, the cerebellum ensures that movement is smooth, accurate, and adaptive. So, cerebellum ensures that movement is smooth, accurate, and adaptive. So, we'll see what are the functional zone of cerebellum. Vermix does the axial control, trunk, and posture. Okay. Intermediate zone for limb coordination, lateral hemispheres, planning and timing of complex movements, fluculonodular lobe, balance and eye movements. So, if patient get a cerebral stroke or tumor, signs will be ataxia, dysmetria, intention tremors, midline lesion, will produce truncal instability, wide-based gait, hemispheric lesion, ipsilateral limb incoordination. So, if fluculonodular damage, nystagmus, balance disturbance. Importantly, cerebellar signs are ipsilateral due to double decussation of cerebellar pathways. So, a right cerebellar lesion causes right-sided ataxia. In trauma, posterior fossa bleeds or herniation can compress the cerebellum. Okay, so leading to rapid disorientation. Always assist with finger, nose, heels, chin, and the Romberg test. So now external structure and functional topography. Now that we have covered the cerebellum's role in coordination and balance, let's examine its external anatomy, which is both elegant and functionally precise. So, cerebellar cortex viewed from the behind resembles a butterfly with a central constricted region called vermis, flanked by two cerebellar hemispheres. These hemispheres are separated by deep fissures and subdivided into lobes, each with distinct roles in motor regulations. So we'll see what are the key external structures. Vermis, the midline structure controlling axial muscle and posture. So vermis, then cerebellar hemispheres, lateral wings managing limb coordinations, tonsil, a part of posterior lobe, clinically relevant in herniation syndromes, uvula and pyramid, components of inferior vermis involved in trunk stability. So each hemisphere is organized into lobes. Anterior lobe receives spinal input important for posture and gait. Posterior lobe coordinates voluntary movement, fine motor control. So, flocculonodular lobe integrates vestibular inputs and balance and eye movement. So if we get a Vermis lesion, patient may get truncal ataxia, white base gait. Hemispheric lesion, ipsilateral incoordination, intention, tremor. Tonsillar herniation, compression of medulla, respiratory arrest. So flocculonodular damage, nystagmus, vertigo, balance disturbances. In trauma or posterior fossa pathology, cerebellar signs are often ipsilateral and subtle. Always assess with coordination test, finger, nose, heel, chin, and rapid alteration movements. Functional zones of the brain, integration and clinical mapping. Now that we have explored the lobes and their roles, let's consolidate our understanding by mapping key cortical regions to their clinical functions. As shown in our diagram, motor cortex, precentral gyrus or frontal lobe controls voluntary movement organized somnotopically. Lesions produce contralateral hemiparesis, often face and arm more than leg. So somatosensory cortex, post-central gyrus or parietal lobe process tactical input such as touch, pressure, pain, and temperature. Lesions may cause contralateral sensory loss. So then Broca's area in the inferior frontal gyrus of dominant hemisphere is speech production. We all know these things already. So lesions may expressive aphasia, non-fluent, effortful speech with preserved comprehension. So in the Wernicke's area, it's Wernicke's area posterior superior temporal gyrus of dominant hemisphere. So its main function is language comprehension. So lesion we call repetitive aphasia, fluent but non-essential speech, poor understanding. Prefrontal cortex, anterior frontal lobe. So it's responsible for executive function, decision making, and personality. Lesion cause disinhibition, poor judgment, emotional blunting. So then Sylvian feature or lateral feature separates frontal and parietal lobes from temporal lobe. This landmark for locating language centers and MCA territory. Then the cerebellum in the posterior cranial fossa. Lobes, layers, and neural architecture. Now that we have explored the external anatomy of cerebellum, let's dissect its internal divisions and layered structure, which reflect both evolutionary design and functional precision. So first we'll see the divisions of cerebellum. Anterior lobe, it receives spinal input, regulates subconscious aspect of posture and gait. So lesions of anterior lobe may cause gait ataxia, especially in chronic alcohol use. What we call it anterior lobe syndrome. So now let's go to the posterior lobe. It coordinates voluntary movement, integrates cerebral input for fine motor control. So lesion in posterior lobe may cause intention tremors, dysmetria, scanning type speech. So flocculonodular lobe located on the inferior surface maintains equilibrium and balance via vestibular connection. So lesion in this flocculonodular lobe cause nystagmus, vertigo, truncal instability. These lobes are functionally distinct but anatomically continuous. working in concert to refine motor output. So now let's go to the layers of cerebellum. Cerebellar cortex, or it's the superficial layers. So it's composed of gray matter folded into slender parallel ridges called folia. Contains three histological layers. What are they? Molecular layer. It's a dendritic arborization. Purkinje cell layer, they are output neurons, and granular layer, input processing. Arbor vitae, it is deep white matter named for its tree-like appearance. So why you call it arbor vitae? Because of tree-like appearance. It carries afferent and efferent signals between cortex and nuclei. Next, we will go to cerebellar nuclei or deep gray matter embedded within the white matter. So this deep gray matter embedded within the white matter include dentate, emboliform, globose, and fastigiae nuclei. Relays, this relays the cerebellar output to brainstem and thalamus. Cerebellar peduncles, gateways of coordination. Now that we have explored lobes and layers of the cerebellum, let's examine its connective architecture. The cerebellar peduncles serves as neural highways linking the cerebellum to the brainstem and spinal cord. There are three paired peduncles, each with distinct roles. Superior cerebellar peduncle, so it's a midbrain connection. Function is major output pathway from cerebellum to the red nucleus and thalamus. Carries afferent fibers from deep cerebellar nuclei. So clinical relevance here is lesions affect motor planning and coordinations. May mimic extrapyramidal signs. So lesions in this area mimic extrapyramidal signs. So now let's go into middle cerebellar peduncle, or we call it Pons connection. Its function is its largest peduncle carries afferent fibers from cerebral cortex via pontine nuclei. So it transmits motor planning signal from cortex to cerebellum. So lesions in this area impair the smooth execution of voluntary movements. So next, inferior cerebellar peduncle or medulla connection. It carries afferent fibers from spinal cord and brainstem, so even including vestibular nuclei. Transmit proprioceptive vestibular inputs. So lesions cause imbalance, vertigo, and sensory. So if you have a lesion in inferior cerebellar peduncle, you may produce imbalance, vertigo, and sensory ataxia. These peduncles integrate the cerebellum into the broader motor system, receiving cortical intent, refining it, and relaying adjustment back to motor centers. So we'll just recap the architecture of internal arrangements. Cerebellar cortex, its gray matter surface with folia. Arbovitae, white matter tracts resembling the tree branches. Cerebellar nuclei, this is deep gray matter, hubs. Dentate, emboliform, globose, and vestigial that sends output via peduncles. Together, these structures form a looped circuit of motor refinements. essential for balance, coordination, and adaptive movement. Cerebellar peduncles, structural bridges, and functional highways. So these cerebellar peduncles considered as structural bridges and functional highways. Now that we have visualized the internal anatomy of the cerebellum, let's focus on its three paired peduncles, the white matter bundles that connect the cerebellum to brainstem. These are not just anatomical bridges, they are functional conduits for motor coordination, sensory integration, and equilibrium. Superior cerebellar peduncle connects to midbrain fiber type primary afferent output. Function is sense process motor signal from cerebellar nucleus to the red nucleus and thalamus. So lesions may mimic extrapyramidal disorders, tremor, dysmetria, and impaired motor planning. So middle cerebral peduncle connects to pons, exclusively afferent fibers. So they are input, transmit motor planning signals from the cerebral cortex via pontine nuclei. Lesions disrupt smooth execution of voluntary movements. Inferior cerebellar peduncle connects to medulla. Here, fibers are mixed but predominantly afferent, carries proprioceptive input from spinal cord and vestibular signal from brainstem. Lesions in this area can cause imbalance, vertigo, sensory ataxia, especially in posterior circulation strokes. These peduncles form the input-output architecture of the cerebellum. Input, middle, and inferior peduncles bring in sensory and cortical data. Output, superior peduncle sends refined motor instruction back to CNS. Yeah. Functions of cerebellum: coordination, balance, and beyond. Now that we have mapped the cerebellar anatomy in its peduncular connections, let's consolidate its functional domains, which extends far beyond simple movement. Coordination of skeletal muscle contractions, the cerebellum fine-tunes voluntary movements initiated by the motor cortex. It ensures fluidity, precision, and timing, transforming intention into execution. So, clinically, lesions can cause dysmetria, intention tremor, so dysdiadokinesia. So, other function, regulation of posture and balance. Through integration with vestibular nuclei, spinal proprioceptors, and visual input, the cerebellum maintains equilibrium. The flocculonodular lobe plays a key role in balance, especially during dynamic movement. Damages can lead to truncal ataxia, vertigo, and wide-based gait. The other function is cognitive and language processing. Emerging evidence shows cerebellar involvement in working memory, attention, and language modulation. The posterior lobe, especially lateral hemispheres, interacts with the prefrontal and temporal cortices. So, cerebellar cognitive affective syndrome includes executive dysfunction, language deficit, and emotional blunting. This triad motor coordination, postural and cognitive modulation make the cerebellum a silent architecture of both movement and thought. Brainstem, the vital axis of life. Now we descend into the brainstem, the compact yet critical conduit between the cerebrum, cerebellum, and spinal cord. It consists of three stacked segments: midbrain, pons, and medulla oblongata. Midbrain, also called mesencephalon. Midbrain is located superiorly, continuous with the diencephalon, contains cerebral peduncles, tectum, and cranial nerves 3 and 4, connected to cerebellum via superior cerebellar peduncle. Clinically, lesions may cause vertical gaze palsy, pupillary abnormalities, or decerebrating posturing. It is from the midbrain. Now we'll go to the pons. Bulging in middle segment. Pons is bulging in middle segment. Anterior to the fourth ventricle, houses cranial nerves 5 to 8, connected to cerebellum via middle cerebellar peduncle. Clinically, lesions affect facial sensation, hearing, and coordination, such as locked-in syndrome if ventral pons is damaged. Finally, medulla oblongata, the inferior segment, continuous with the spinal cord, contains cranial nerve 9 to 12, cardiorespiratory centers, and decussation of pyramids, connected to cerebellum via inferior cerebellar peduncle. Lesions may cause dysphagia, dysarthria, respiratory failure, or sudden death. The posterior aspect of the pons and medulla forms the floor of fourth ventricle. So, posterior aspect of the pons and medulla forms the floor of the fourth ventricle, a key landmark in hydrocephalus and posterior fossa pathology. Midbrain, gateway of reflexes and alertness. Now we ascend to midbrain or mesencephalon, a compact yet vital segment of the brainstem, measuring approximately 2.5 cm in length. It bridges the pons below the diencephalon above, forming a conduit for ascending and descending neural traffic. Anteriorly, cerebral peduncles, its motor pathway from cortex to spinal cord, then posteriorly tectum, contains superior and inferior colliculi. So then central core is the tegmentum, houses red nucleus, substantia nigra, and reticular formation. Cranial nerve 3, oculomotor nerve, and cranial nerve 4, trochlea, emerges here. So what are the functional domains? Motor control via corticospinal and corticobulbar tracts. Visual reflex. So visual reflexes, superior colliculi coordinate the saccades and tracking. Auditory reflexes, inferior colliculi relay sound localization. So arousal and alertness, it's a very important function. So reticular activating system modulates consciousness, temperature regulation, and pain modulation via preaqueductal gray. So clinical correlations we can see here are Weber syndrome, ipsilateral cranial nerve 3 palsy plus contralateral hemiparesis. In Benedict syndrome, you get third cranial nerve palsy plus tremor and ataxia. Likewise, Parkinson disease, degeneration of substantia nigra, dopaminergic deficits. It causes dopaminergic deficits. The midbrain is not just a relay, it's a reflex integrator, a motor modulator, and a conscious regulator. In trauma, infarct, or compression, midbrain signs are often dramatic and life-threatening. So now let's go to the core features of the midbrain mesencephalon. It's located between the pons and diencephalon, 2.5 centimeter long, functions as a relay for impulses and between brain and spinal cord, as we discussed earlier. So there are two parts, especially I put this side to understand the parts of the midbrain. Anterior part, you have cerebral peduncles, crus cerebri, crus cerebri, they are white matter tracts for voluntary motor control, and tegmentum contains substantia nigra, which inhibits unwanted muscle activity. Then we'll go to the posterior part of tectum. It contains superior colliculi. For- So for the visual reflexes, example tracking, and inferior colliculi, they relays the auditory. So the auditory relate to thalamus. The midbrain also regulates alertness, sleep-wake cycle, temperature, and basic motor functions, making it vital for both reflexes and consciousness. So midbrain reflexes rely on dopaminergic drive. So we'll go a little deep into that. Building on our anatomical overview, let's now explore the functional domains of the midbrain, a compact powerhouse responsible for integrating movement, sensation, and alertness. Motor movements, especially eye movements. The cerebral peduncles carry descending motor fibers from the cortex. Cranial nerve 3 and 4 emerge here, controlling extraocular muscles. So then auditory and visual processing, it's done by the superior colliculi, coordinate visual reflex, tracking, and saccades. Inferior colliculi relay auditory signals to thalamus. So then dopaminergic modulation, excitation, and motivation. Substantia nigra and ventral tegmental area VTA produce dopamine. Dopamine regulates motor control, reward, and motivation. So relay and regulations act as a conduit for ascending sensory and descending motor tracts. Modulates aerosols, sleep-wake cycles, and temperature regulation. Pons, the bridge of integration. Next in our brainstem journey is the pons, aptly named from the Latin for bridge, as it connects the cerebellum to rest of the brain and lies between the midbrain above the medulla below, anterior to fourth ventricle. So let's see the structural outline. So structure overview is anterior surface is bulging with transverse fibers forming basilar groove. Posterior surface forms the floor of the fourth ventricle. So trigeminal, abductions, facial, and vestibular cochlea are emerge here. So what are the functional domains of the pons? Motor and sensory relay contains ascending sensory and descending motor tracts. Cerebellar connection. It has a cerebellar connection via middle cerebellar peduncle, largest afferent pathway. It has autonomic nuclein, regulate the respiration, bladder control, and swallowing. So somatic nucleus control facial expression, eye movement, hearing, and equilibrium. Then let's see what are the clinical importance here. Locked-in syndrome. So bilateral ventral pontine infarct may cause quadriplegia with preserved consciousness and vertical eye movements. There may be facial palsy, lesion of facial nerve nucleus or fascicle. Internuclear ophthalmoplegia, lesion of medial longitudinal fasciculus (MLF), cause the internuclear ophthalmoplegia. So, what about the pontine hemorrhage? It's caused rapid deterioration due to proximity to vital centers. So the pons is not just a bridge; it's a hub of cranial nerve activity, a relay station, and respiratory regulator. In trauma or infarct, pontine signs are often bilateral and devastating. Medulla oblongata, a vital relay and reflex center. Completing our journey through the brainstem, we arrive at the medulla oblongata, the lowermost segment of the brainstem, continues with the spinal cord and nestled within the foramen magnum. So its length is about 3 centimeters, located between the bones and the spinal cord below. Posterior surface forms part of the floor of the fourth ventricle. Glossopharyngeal, vagus, accessory, and hypoglossal nerves emerge here. Then motor and sensory tracts, all ascending and descending white matter tracts pass through this area. So it's a vital autonomic center. It's a cardiac center. It regulates the heart rate, to act as a vasomotor center to control, regulates the blood pressure. Also respiratory center modulates the breathing rhythm. Reflex centers, swallowing, coughing, and sneezing, and noting all the important functions. So clinically, if you get a medullary stroke, so patient will produce lateral medullary syndrome, dysphagia, hoarseness, vertigo, ipsilateral facial sensory loss, contralateral body sensory loss. It's important point in the lateral medullary syndrome. So, if a central medullary lesion, bilateral motor weakness due to corticospinal tract involvement, and compression at foramen magnum or tonsillar hernias fatal in respiratory centers are as respiratory centers are compromised. Yeah, it is fatal if respiratory centers are compromised. The medulla is the life-sustaining core of the brainstem, regulating autonomic functions, relying sensory input, executing reflexes. In trauma and infarct, medullary signs are often dramatic and demand urgent intervention. So, beyond its role as conduit for motor and sensory tracts, the medulla oblongata houses several critical regulatory centers that sustain life and coordinate involuntary functions. What are those? Cardiovascular center, medullary rhythmicity center. So this medullary rhythmicity center controls the basic rhythm of breathing. So then vasomotor center adjusts the diameter of blood vessels to regulate blood pressure. So response to baroreceptors input from carotid sinus and aortic arch, and reflex centers. So reflex centers coordinate swallowing, vomiting, coughing, sneezing, and hiccuping. These are protective and homeostatic reflexes. Then cranial nerve nuclei. 5 pairs of cranial nerve originate here, 9 to 12 and part of 8. So it controls speech, swallowing and tongue movements, and visceral sensation. The medulla is the autonomic command center, regulating cardiovascular, respiratory rhythms, executing reflexes, and integrating cranial nerve functions. In trauma, infarct, or herniation, medullary compromise is often rapidly fatal. Diencephalon, sensory gateway and autonomic command. Now we ascend to the diencephalon, a central relay and regulatory hub nestled between the cerebral hemispheres and brainstem. It comprises three key structures: thalamus, hypothalamus, epithalamus. So, as you all know, the thalamus, its main function is major sensory relay station, receive, process, and forward sensory input to cerebral cortex. So it handles touch, pain, temperature, proprioception, and special senses. So hypothalamus, its main function is autonomic and endocrine control center. So it's a autonomic and endocrine control center, regulates body temperature, hunger, thirst, circadian rhythms, and emotions, controls pituitary gland via hormonal signals. Then finally epithalamus. It includes pineal gland, which secretes melatonin, regulating sleep-wake cycle, involving circadian rhythm, reproducing timing, and seasonal mode regulation. Together, these structures form the functional core of sensory integration, autonomic regulation, and hormonal control within the cerebral cortex with the limbic system and brainstem. Thalamus, gateway to conscious sensation. Now we focus on the thalamus, the largest component of the diencephalon, accounting for nearly 80% of its mass. It sits deep in the brain, perched atop brainstem like an inner room, as its Greek name suggests. So, thalamus. Location, it's a bilateral flanking the third ventricle. It's it's a dense cluster of gray matter nuclei. It receives input from spinal cord, brainstem, basal ganglia, and cerebellum. Relays to cerebral cortex. So sensory relay, all sensory modalities except smell pass through the thalamus before reaching the cortex. Pain, temperature, touch, pressure, proprioception, visual and auditory pathways. So then motor modulation interacts with basal ganglia and cerebellum. Next function is consciousness and alertness, part of the reticular activating system. It's a part of reticular activating system. And emotion and memory linked to limbic system via anterior and medial nuclei. So clinically, if there's a thalamic stroke, contralateral sensory loss, thalamic pain syndrome, thalamic neglect, inattention and contralateral stimuli, Korsakoff syndrome. It's due to damage to dorsomedial nucleus. It causes antegrade amnesia. If bilateral thalamic infarcts, it's impairs arousal and awareness, causing vegetative states. The thalamus is not just a relay, it's a sensory integrator, a motor modulator, and conscious gatekeeper. Its dysfunction can mimic cortical lesions or produce profound sensory disorientation. So, thalamic nuclei, its precision relays to the cortex. Having stabilized thalamus as the gateway of the cerebral cortex, now let's examine the specialized nuclei, each dedicated to relying distinct sensory modalities to specific cortical areas. Medial geniculate nucleus, so its function is auditory relay, receives input from the inferior colliculus, projects to the primary auditory cortex in the temporal lobe. So then lateral geniculate nuclei, LGN, it's a visual relay, receives input from the optic tract, projects to the primary visual cortex in occipital lobe. Then ventral posterior nucleus (VPN). It's a somatosensory relay. So it has two VPL and VPM. VPL is ventral posterior nucleus lateral and VPM is medial. So VPL receives the body sensation while the VPM facial sensation and taste projects to the primary somatosensory cortex in the parietal lobe. So these nucleus ensures that sensory data is filtered, organized, and directed to appropriate cortical regions for conscious perception and integration. Hypothalamus, the master regulator of homeostasis. Now we turn to the hypothalamus, a compact but powerful structure located beneath the hypothalamus, forming flow, flow of the third ventricle and extending toward the pituitary gland. So now hypothalamus, a compact powerful structure located beneath thalamus, forming the floor of the third ventricle and extending towards the pituitary gland. Despite its small size, the hypothalamus orchestrates a vast array of autonomic, endocrine, and behavioral functions, making it executive center of internal balance. So we'll see what are the key regulatory roles of hypothalamus. Autonomic nerve system control, modulate sympathetic and parasympathetic output, regulate heart rate, blood pressure, digestion, and pupil size. So now let's turn into endocrine system control. It directs the pituitary gland via releasing and inhibiting hormones, governs growth, metabolism, reproduction, and stress response. So now let's see how it what are the homeostatic functions. It controls the temperature, it controls thermoregulation via the anterior and posterior hypothalamic zones, appetite and satiety. So hunger and satiety controlled by the center. Then sleep wake cycle via suprachiasmatic nucleus. This is what we call circadian rhythm. And emotional and behavioral integration interfaces with limbic system to modulate fear, aggression, and pleasure. So coordinates behavioral response to internal states. The hypothalamus is the command center of survival, regulating everything from thirst to thermoregulation, emotion, endocrine output. Its dysfunction can mimic psychiatric, endocrine, or autonomic disorders. Epithalamus and pineal gland, the circadian gatekeepers. Completing our tour of the diencephalon, now turn to the epithalamus, a small but functionally significant region located superior and posterior to the thalamus, forming part of the roof of the third ventricle. Its key component is the pineal gland, a pea-sized endocrine organ that protrudes from the posterior midline and plays a central role in regulating circadian rhythm. So pineal gland's function secretes melatonin, a hormone that promotes sleepiness. So melatonin release is stimulated by darkness and inhibited by light. So regulate biological clocks, seasonal rhythms, and reproductive timing. Influence mood, alertness, and sleep-wake cycle. Pineal tumors may compress the tectum of midbrain, causing Parinaud syndrome. So melatonin dysregulation linked to insomnia, seasonal affective of disorders, and jet lag. So Calcification in this area common with the age, visible on CT scan and used as a midline marker. The epithalamus is a neuroendocrine interface translating environmental cues into hormonal signals that modulate behavior, sleep, and mood. Before we move further, it's important to note that 12 pairs of cranial nerves arises directly from the brain within the cranial cavity. These nerves pass through the bones of cranium and are classified as sensory, motor, or mixed, depending on their function. Each nerve plays a vital role in sensation, movement, reflex, and autonomic regulation, and their nuclei are intricately mapped across the brainstem. We'll explore the cranial nerve in detail in a dedicated lecture covering their anatomical origins, functional classifications, and clinical syndromes. Thank you.